Okay, so we were discussing acute coronary syndrome, and we have completed the physiological basis of acute coronary syndrome, and we are left with the heart block, right. But before I enter into heart block, I had skipped one thing that I need to discuss today, that is determination of ECG axis. Okay. So, I had taught determination of ECG axis by a simple rule called the thumb rule, right, the thumb rule, and you have known that, right. So, determination of ECG axis by thumb rule, whether it is normal axis, left axis deviation or right axis deviation. So, if you remember this, we had determined ECG axis with the help of our thumb, right. So, say for example, this ECG. So, we have seen lead 1 is predominantly upward and lead AVF is also predominantly upward. Okay. So, I with our left thumb and right thumb. So, left thumb up, right thumb up. So, it is normal axis. Okay. So, it is normal axis. But if I ask you what is the exact axis or what is the angle of the axis, which is a very important question at your first professional MBBS examination, maybe it will be asked in practical examination, or maybe it will be coming in your theory exam as well, right. So, determination of actual axis in degrees. Okay. So, what is the normal axis range? Minus 30 to plus 110 degree, right. Okay. So, minus 30 to plus 110 degree is the normal axis. Okay. So, here I can say with the help of thumb rule that it is normal axis, but I can't exactly tell whether the axis is 60 degree or 70 degree. So, today we will learn how to determine ECG axis very accurately. Okay. How to determine ECG axis very accurately in degrees. Okay. So, to do that, I told that you need a scale, a protractor, right, and pencil, right. Okay. So, today we will determine the exact axis from, say for example, this ECG. Draw the graph. So, this is 0 degree, right. This is 0 degree where you have lead 1. Okay. So, 0 degree you have lead 1. Okay. Now, this is plus 90 degree and plus 90 degree is lead AVF. Okay. Now, I need to draw lead 2. Lead 2 is at 60 degree, plus 60 degree, right. So, here is lead 2, it is at plus 60 degree. Okay. Now, let us extend lead 2 backward. Okay. Now, what we need to see, we need to check the height of QRS complex at lead 1 and lead 2. Okay. So, here we can see lead 1 and lead 2, we need to check the height of QRS complexes. Okay. The height of QRS complexes, how to check? Okay. So, can you see lead 1 and lead 2, we need to calculate the height of QRS complex. So, first look at lead 1. Okay. So, I told you that one small square vertically is equal to 0.1 millivolt, because in this ECG axis y axis is voltage and x axis is time. Okay. So, a small square in the upward direction or vertical direction is 0.1 millivolt. Okay. And one small square in the horizontal line is 0.04 second. Okay. I guess you know. So, let us check the height of QRS complex in lead 1. So, it is, yes, 5 small squares. Okay. It is 5 small squares. Everyone agrees it is 5 small squares. Okay, now QRS complex in lead 2. How many small squares? So 5, 5, 10, 11, 12 almost. 5, 5, 5, 5, 10, 11, 12. Okay. So, can you see here in lead 2 there is slight negative deflection as well. Okay. So, that is Q, right. Q is minus 1. Okay. Q is minus 1. So, we need to determine the net QRS voltage. Okay. Net QRS voltage. So, as we see, it is, suppose it is plus 12 in the upward direction and minus 1 in the downward direction. So, net QRS voltage will be plus 11. Okay. Net QRS voltage will be plus 11. So, we got plus 11 for lead 2 and plus 5 for lead 1. Okay. Now, with the help of a scale, you need to draw this. If this question comes in your professional examination or in the practical examination, you need to draw this lead 1 and lead 2, right. And at an interval of 1 centimeter or half centimeter, but it should be equal for all the axes, right. So, say for example, I am taking points at an interval of 1 centimeter. Okay. So, this is 1, 2, 3, 4, 5, 6 and here minus 1, minus 2, minus 3, minus 4, minus 5. In case of lead 2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, right. Okay. So, in our example, in this ECG, the point is, the central point is 0, plus 1, plus 2, plus 3, plus 4, plus 5, right. So, here is the point. Clear? Okay. Now, in case of lead 2, it is plus 11, right, plus 11, because plus 12 minus 1, it is plus 12, plus 11. Okay. So, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So, here is the point, plus 11, right. Okay. Eta jodi negative hoto, mane lead 2 te ekhon positive in this ECG, in this example, lead 2 is predominantly positive, but had it been the case that lead 2 is predominantly negative, then you need to mark it in this direction. Clear? Okay. Now, on both the points, you need to draw a vertical. Okay. On both the points, you need to draw a vertical. So, I am drawing a vertical with a different color. So, a vertical on this point and a vertical on this point on lead 2. Clear? Okay. Now, these two verticals will intersect at a point. Okay. So, here is this point. Clear? Now, I have to connect the central point with this. Clear? Okay. So, what is this? This is mean electrical axis. Okay. This is how we find mean electrical axis in an ECG. Now use a protractor and measure this angle. Okay. Measure this angle with a protractor and you get ECG axis. Okay. So lead 2 is plus 60 degree. So it is somewhat beyond that. So it may be 70 degree or 75 degree around. Okay. Right. Okay. So this is how we calculate the exact angle of ECG axis, and the normal axis you already know. Normal axis you already know, it is minus 30 to plus 110 degrees, and here in our example it is coming to 70 or 75 degree, and it is normal axis. Okay. Now let us take a different example where there is axis deviation and then calculate the thing. Okay. Axis now আসতে পারে, normal axis হলে easy হয়ে যাবে draw করা. Lead 2, right? Okay. So now check the voltages in lead 1 and lead 2. So in lead 1 it is কত? 2, 3, 4, 5, 6 নাকি? Okay, so plus 6. Okay. Roughly you need to calculate, otherwise in computerized ECG all the heights are given, calculated by the computer, right? Okay. So it is plus 6 in lead 1, right? Lead 1 plus 6. Now lead 2. So it is something plus, something minus, right? So plus is plus 3 we can consider, and down is 1, 2, 3, 4, 5, 6, right? Okay. So plus 6 minus plus 3 minus 6. Okay. So plus 3 minus 6, it is coming to minus 3. Okay. So lead 2 minus 3. So in lead 2 our point will be this. Okay. Minus 1, minus 2, minus 3, lead 2, and plus 6. 1, 2, 3, 4, 5, 6. Here is the point, plus 6. Okay. Here is minus 3. Clear? Now you draw vertical on both the points. In case of lead 1, this is the vertical you draw, and in case of lead 2, this is the vertical you draw, and both the vertical are meeting it at this intersect point, right? Clear? Now the axis is, and the angle is this. Okay. And the normal axis range, you know, it is minus 30 to plus 110. So this is the range. This is the range of normal axis, and here it is the main electrical axis. Okay. So it will be coming to around minus 60 degree or somewhat, minus 60 or minus 70 degree, somewhat like that. Okay. So you know, from 0 degree this side is positive and this side is negative, right? So it will be coming around minus 60 degree or minus 70 degree, and it is left axis deviation. Okay. It is left axis deviation, most probably in a case of left ventricular hypertrophy, or it may be a case of left anterior hemiblock. Okay. We have not studied block yet, we will start block, heart block. Okay. Clear? You should be, it is a basic competency in first professional MBBS curriculum. You need to be able to calculate heart rate from an ECG, you need to be able to calculate ECG axis. Okay. But remember, this is for learning purpose. In our clinic, usually when we see patients, we interpret an ECG, we always use the thumb rule, because the exact degree is not required actually when you are doing your clinical practice, right? But you need to have idea. Okay. So very often gradually we will have an experience that simply by seeing the heights of the QRS complex, simply by seeing the heights of the QRS complex or voltage of the QRS complex, we can assume that it should be between 60 degree and 70 degree, it should be between 50 degree and 60 degree, right. So it's a practice. Every time not necessarily you need to draw this, it is your clinical practice. So gradually you will be able to assume what the degree is, right. But this is the accurate method. You need to perform this in your practical examination, and if theory question comes on this, you need to draw this. Okay. And don't forget to take those pencils, scale and protractor during your practical examination, because this question frequently comes. Axis determination from an ECG. Okay. It is a basic skill, axis determination and heart rate determination from an ECG. So now we will be entering into heart block. Okay. So heart block essentially means conduction block. Okay. Heart block essentially means conduction block. So we have conduction fibers that supply depolarization wave or action potential from the SA node to the ventricle ultimately, right. So the conduction pathway, if you remember, it starts from SA node to AV node. We have internodal tracts, right. We have internodal tracts, and from AV node we have bundle of His, and bundle of His at the upper part of the interventricular septum, it divides into the left bundle branch and right bundle branch. As your left ventricular muscle mass is more and it needs more electricity supply, so left bundle branch again divides into two, which is anterior fascicle, which supply the anterior part of the left ventricle, and posterior fascicle, which supply the posterior part of the left ventricle, right. Now block can happen anywhere within the conduction fibers, okay, and we call it heart block. Okay. So conduction block may be at the level of AV node, it may be at the level of bundle of His, it may be at the level of right bundle branch or left bundle branch, or it may be a particular fascicle of left bundle branch, like the block in the anterior fascicle or block in the posterior fascicle. Okay. And few blocks are common and few blocks are rare. Okay. So this picture should be clear to everyone. Okay. I just talked about from SA node is not shown here. So from it is the only the ventricular area has been shown here. So AV node at the atrioventricular groove, and at the upper part of the interventricular septum we have the bundle of His. It divides into right bundle branch and left bundle branch. Left bundle branch again divides into the anterior fascicle and posterior fascicle. Posterior fascicle supply the posterior part of the left ventricle, anterior fascicle supply means electricity supply, not blood supply, right. Okay. So anterior fascicle supply, for blood supply we have coronary arteries. So this is the conduction fibers which are meant for electricity supply, okay, supply of action potential, okay, or depolarization wave. Okay. So this is anterior fascicle and this is posterior fascicle, right. Okay. So before that, tell me about PR interval and what PR interval means in an ECG. What PR interval means? Okay. What PR interval means? From the start of the P wave to from the start of P wave to the beginning of Q wave. Okay. Although it is called PR, the duration is from the start of P to the beginning of Q. Here is the start of P and here is the beginning of Q. So this duration is called PR interval. Clear? PR interval. What does PR interval means? It is the time duration that is required for the action potential to travel from atria to ventricle. Okay, from atria to ventricle. It is the time duration taken by the action potential to move from atria to ventricle. Because you know P wave is atrial depolarization. Okay, P wave is atrial depolarization and QRS is ventricular depolarization. QRS is ventricular depolarization. Total QRS is ventricular depolarization and T is ventricular repolarization. Okay, so we can segregate P wave is the atrial wave and QRS is the ventricular wave. Okay, so from the start of P to the beginning of Q, that means action potential which takes PR interval time to travel from atria to ventricle. Okay, so this is PR interval and it should not be, normally in a healthy individual, it should not be more than, what is the normal range of PR interval? Very important. Okay, what is the normal range of PR interval? Normal range of PR interval is 0.12 to 0.2 second. This is normal PR interval. In the x-axis, we see times, right? So 0.12 second means how many small squares? 3 small squares, because one small square is equal to 0.04 second. Okay, so 3 small squares is equal to 0.12 second. Okay, and 5 small square is equal to 0.2 second, right? 5 small square means 0.2 second. So that essentially means PR interval should be 3 to 5 small squares. Clear? PR interval should be 3 to 5 small squares. If PR interval is short, it will be less than 3 small square, that means 1 small square or 2 small squares. And if PR interval is more than 5 small squares, that means more than 0.2 second, we call it PR interval is increased. Okay? So now we will see an ECG. So now see it and check how many small squares are there in PR interval. Okay? How many small squares are there in PR interval? So here is the P wave. Okay? If you take the first complex, here is the P wave, here is the P wave. Okay? So you see 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay? So 9 small squares from the beginning of P to the beginning of Q. 9 small squares. 1 small square is equal to 0.04 second, right? 1 small square is equal to 0.04 second. So 9 small square will be 0.36 second. If I convert it into millisecond, it will be 360 millisecond. Okay? So here you see 360 millisecond. So PR interval is increased, prolonged. Okay? So in the first complex, again you see 1, 2, 3, 4, 5, 6, 7, 8, 9. Again in the second complex, you see 1, 2, 3, 4, 5, 6, 7, 8, 9. Again in the third complex, 1, 2, 3, 4, 5, 6, 7, 8, 9. That means PR interval is fixed and increased. Okay? PR interval is fixed and increased. It is more than 5 small squares, that means more than 0.2 second, 0.36 second here. So PR interval is increased and fixed. We call it first degree heart block. Okay? We call it first degree heart block. Okay, first degree heart block is usually an incidental finding. That means patients usually do not have any symptoms. Patients usually do not have any symptoms for first degree heart block. Actually what happens, we prescribe ECG for some different reason. Maybe the patient will be undergoing some surgery, and as a part of pre-surgery workup, as a part of pre-surgery investigation, patient has done ECG, and suddenly we find that there is a first degree heart block. Okay. So, first degree heart block is clinically inert, that means patients do not have any symptoms, and patient will not be coming to you or any doctor with the complaints of any cardiology symptoms, right. It is an incidental finding. किसी ने suddenly ECG किया तो suddenly we find that there is a first degree heart block, and we don't need any treatment for first degree heart block. ठीक है, we don't need any treatment for first degree heart block, we leave it as such, but the patient is advised to follow up. Okay, patient is advised to follow up. Follow up means you perform an ECG every 6 months or every year you perform an ECG and see the progress. If it is progressing to further block, second degree heart block or third degree heart block, right. So, a follow up ECG is prescribed, but no treatment is required, and the patient is usually asymptomatic, it is an incidental finding. So, this is all about first degree heart block. Okay. In your practical examination, in OSPE, objective structure practical examination, okay, maybe some abnormal ECG, within abnormal ECG, I told you, you need to identify few abnormal ECGs, and out of which most important is acute coronary syndrome. Okay, out of which most important is acute coronary syndrome. Next is the heart block. So, heart block ECGs will be there, will be placed in practical examination, and you need to identify. Okay, and don't say it is heart block, you say it is first degree heart block. Okay. Okay, so to identify first degree heart block, you need to calculate just PR interval and check all the complexes whether this increased PR interval is same for all the complexes. Okay, so it is first degree heart block. Now, in this typical ECG, you see PR interval is 260 milliseconds. So, that is definitely increased. So, upper limit of PR interval in millisecond is 200, 0.2 second, that is 200 milliseconds. So, it is 260 millisecond, that means increased, yes. So, in the first complex it is 260 millisecond, in the second complex it is 280 millisecond, third complex it is 320 millisecond. So, gradually PR interval is increasing, okay. Gradually PR interval is increasing, and it will happen until a point where P wave will not be followed by a QRS complex, okay. Normally in an ECG, P wave is followed by a QRS complex. After P wave, QRS complex ko aana hi hai, right? But here you see P wave, then QRS complex, P wave, then QRS complex, P wave, then QRS complex. Here is a P wave, then there is a gap, no QRS complex. Okay. So, after P there is a gap, and again there is a P. Getting my point? Okay. So, here is P, no QRS complex followed by the P, and again is a P. Okay, so in this case, which is called the second degree heart block or Wenckebach phenomenon or Mobis type 1 heart block, okay, Mobis type 1 heart block or second degree heart block, Mobis type 1, okay. So, the thing is PR interval will increase in subsequent bit until a point where P wave will not be followed by a QRS complex. Clear? This is second degree heart block, Mobis type 1. You need to identify that. So, difference from first degree heart block is that in first degree heart block, PR interval is increased and fixed, and there is no skip in QRS complex. Always P wave will be followed by a QRS complex. But in second degree heart block, PR interval is increased, but gradually it will further increase until a point where P wave will not be followed by a QRS complex. Okay. Tale P wave is atrial depolarization, QRS complex is ventricular depolarization. In between we have AV node, right. From atria to ventricle we need to cross the AV node. For the action potential to travel from atria to ventricle, we need to cross the AV node. Okay. So there is some problem at the level of AV node, right? Okay. So in first degree heart block, AV node is taking more time to transmit the impulse from atria to ventricle, right? Okay. Now here in this case, in case of second degree heart block, impulse is coming from atria to ventricle, next impulse is coming slower, next impulse again slower, and then an impulse is beginning at the level of atria, it is not traveling to ventricle. Okay. So this thing is happening at the level of AV node, right? Okay. So all these blocks are at the level of AV node, first degree heart block, second degree heart block, right? Okay. Everyone clear what is second degree heart block Mobis type 1, so that I can move to the next. Okay. Second degree heart block Mobis type 2. Okay. In case of second degree heart block Mobis type 2, PR interval is increased and fixed. PR interval is increased and fixed. But in subsequent bit, there will be a skip in QRS complex. Okay. So what is the difference between Mobis type 1 and type 2? In case of Mobis type 1, PR interval is gradually increasing until a point where P wave is not followed by a QRS complex. But in case of Mobis type 2, what is happening? PR interval is increased and fixed, but yes, after certain time, one P wave is not followed by a QRS complex, there is a gap. Okay. PR interval is not gradually increasing, it is increased and fixed, but still after certain bits, one ventricular complex is absent. P wave is not followed by a QRS complex, and after P wave there is another P wave. Clear? This is Mobis type 2. Okay. And if you talk about the consequences, it is a more serious condition than the previous one. Okay. The patient in both the cases, Mobis type 1 and Mobis type 2, the patient will be complaining of dyspnea, palpitation. Okay. Patient will be complaining of these symptoms. And if we talk about seriousness, Mobis type 2 is much more dangerous, which frequently convert into complete heart block. Okay. Okay. Treatment is not required at your level. Okay, for how many P we have one QRS complex, depending on that we divide second degree heart block into 2:1, 3:1 in this way, right? Okay, now come to third degree heart block. Third degree heart block is also called the complete heart block. Okay, third degree heart block is also called CHB or complete heart block. What do you see here? Any idea? What do you see here? কি দেখতে পাচ্ছ এখানে? কি প্রবলেম হচ্ছে? If we compare it with first degree heart block and second degree heart block Mobis type 1 and type 2, what is happening over here? T wave inversion hone do, that is the reason is different. Yes, nothing is fixed here. Nothing is fixed here. There is no relation. Okay. In first degree heart block, P wave and QRS complex had a relation after an increased time, but after an increased time QRS complex is supposed to come, right? And in second degree heart block, time interval was increasing until a point where P wave is not followed by a QRS complex, and in type 2 PR interval is increased, but after a certain period of time it will not be followed by a QRS complex, right? But here there is absolutely no relation between P wave and QRS complex. Okay, so you see P wave here, P wave here, P wave here, P wave here. Okay, P wave যখন খুশি হচ্ছে, QRS complex যখন খুশি হচ্ছে. Absolutely there is no relation, bizarre, right? So it is called atrioventricular dissociation. Okay, atria and ventricle, they have divorced each other. ठीक है, तुम अपने हिसाब से चलो, मैं अपने हिसाब से चलता हूं. This is the thing. ठीक है, and this bit is ineffective. Okay, when the patient is having complete heart block, definitely the patient will have dyspnea, palpitation, this sort of symptoms. Okay, and it is a medical emergency where you need to put a pacemaker. Okay, complete heart block is a medical emergency where you need to put a pacemaker. Because in this condition, when atria is beating on its own, ventricle is beating on its own, there is completely no relation, no synchronization, and when the heart is beating, this beat is not adequate to pump blood into the systemic circulation, right? So, we need to treat the patient as early as possible, preferably by putting a temporary pacemaker, and we can consider doing the pacemaker permanently in the course of time, right? Okay. Anyway, treatment is not required. For your level, what is required, you need to identify by seeing an ECG what is first degree heart block, what is second degree heart block, MBBS type 1 and type 2, and third degree heart block. Okay? Clear everyone? Okay. So, today's was a small topic. I will not talk more because also attendance is less. Okay. So, we have what we have covered. We have covered normal ECG. We have covered heart rate determination from an ECG. We have covered heart rate determination from an ECG, 1500 by, not covered, okay. Okay, so how to determine heart rate from an ECG? It will take hardly 1 to 2 minutes. Heart rate determination from an ECG. Determination of heart rate from an ECG. How to determine heart rate from an ECG? So, take this example. So, here is lead 2, right? Here is lead 2. Here is lead 2. See the below curve, it is lead 2. Take any R interval. So, this is R wave, right? This is QRS complex, this is QRS complex, this is QRS complex. Okay. Check here, it is lead 2, right? So, in lead 2, take any R subsequent, right? So, say for example, this R wave and this R wave, this R wave and this R wave. So, how many small squares are in between? Okay. So, this is 5, 5, 5, 15, 15, here 3, 18 and here 4, 22. Okay. So, say for example, there are 22 small squares between this R and this R, 22 small square, okay, 22 small square. So, how to determine heart rate? The formula of heart rate is 1500 divided by the number of small square, 1500 divided by number of small square, okay. So, 1500 divided by number of small square, here it is 22. ওকে ঠিক আছে এবার এটা যেটা আসবে ফ্র্যাকশনাল পয়েন্ট যেটা আসবে সেটা বাদ দেবে যেটা নাম্বারটা আসবে ইন্টিজার রাইট ওকে সো ইট উইল বি কামিং আউট সামথিং অ্যারাউন্ড 74 or 73 লাইক কত আসছে 70 68 point something ওকে ঠিক আছে সো 68 is the heart rate 68 per minute ठीक है যদি 20 small square হতো তাহলে 1500 divided by 20 that is 75 per minute okay so this is how we determine heart rate from an ECG check the number of small square between two adjacent R wave okay or measure RR interval in terms of small squares and 1500 divided by the number of small square gives you the heart rate okay and do it from lead to convenient okay now tell me why it is 1500 why do we divide the number of small square is correct to some extent so see here something is written can you see speed 25 mm per second. That means, if you see the ECG machine, the paper strip comes out the speed we can change, and conventionally we do ECG while the paper strip comes out, sit down, the paper strip comes out from the machine at a rate of 25 millimeter per second. Okay. The paper strip for electrocardiogram, the machine emits the paper at a rate of 25 mm per second. You can change it to 50 mm per second as well, but conventionally while doing ECG we do it at 25 mm per second. Okay. For wave analysis, again we can increase the speed so that the waves are spread out. Okay. যদি আমি ECG পেপারের স্পিডটা পেপার থেকে যে স্পিডে ECG পেপারটা বের হচ্ছে সেটাকে বাড়িয়ে দিই, if I do it at, set it at 50 mm per second, what will happen? No, it will spread out. Okay. पेपर तो जल्दी निकल रहा है, right? So this ECG wave, say this is an ECG complex, right? A single complex. Now it will be, right? So it will be spread out. And if I decrease the speed, then waves will be congested, condensed, right? Okay. So the normal rule is when the paper strip is emitting at a rate of 25 mm per second, the formula will be for heart rate is equal to 1500 divided by number of small square. Okay, 1500 divided by number of small square in RR interval, number of small square in between two adjacent R wave, right? Okay, why 1500? This is because 25 mm per second, okay, and 1 minute means 60 seconds, so 60 into 25 you get 1500, okay. Okay, in exam we can give you a different ECG where the speed is 50 mm per second, then you need to divide RR interval 3000 by RR interval, okay. Then your formula will change, heart rate will be 3000 by RR interval. But conventionally for all ECGs, for all clinical practices we do ECGs at rate of 25 mm per second, okay, and you apply the formula 1500 divided by RR interval in terms of small square, it gives you the heart rate. So we have learned the basic things from ECG, that is determination of heart rate, determination of actual heart rate. Heart rate normally we determine from pulse, but I told there may be some bits which are not able to generate pulse, so that is why the best method to determine heart rate is from the ECG, right? Okay, so determination of heart rate, determination of ECG axis we have learned, which is a very basic thing in your first professional MBBS examination, right? Then we need to identify some abnormal ECGs, and out of which most important is acute coronary syndrome, second is heart block, and one part is already remaining, that is identifying an ECG of arrhythmia or rhythm disturbances, okay. So we will proceed to our next ECG class, okay, if it happens at all before fest, right. So that next class will be on rhythm disturbances or arrhythmia, ठीक है.